Okay, so now that we've started the webinar, it does take a little bit as all the participants are coming into the room. And I don't want to get too far ahead of myself and run into all the information while I know people are loading in. We did have about 175 folks that registered for the evening seminar tonight, which is a great number. I know this topic is absolutely very relevant for so many in our community. So I've got about 56 in the room right now, Holly. I would love to introduce tonight our Executive Director of the Breast Cancer Coalition, Holly Anderson. Tonight, she would like to just make a few opening remarks. So go right ahead, Holly.
Thank you. Thank you so much, Christina. Welcome to this wonderful seminar. We're so excited to have Dr. Ruth O'Regan, who's the chair of medicine, among many other hats that she wears at the University of Rochester Medical Center. I think she arrived in the winter of 2021, and shortly after, within weeks actually, she graced us with a visit right at the Breast Cancer Coalition. It was a pleasure to welcome her there, and she's been back several times since. We've collaborated in a number of ways. She has welcomed a couple of survivor advocates onto a research project. These are survivor advocates that sit on our research committee. If you are interested in those sorts of collaborations, I encourage you to join our research committee. Just reach out to us at info@bccr.org. Always room for more. Even if you think you don't bring a lot of science or technical skills to the table, you bring your own experience as survivors. We really want to see more survivors at the table where these decisions get made. Currently, we are completing year 6 of a New York State Department of Health funded program that helps folks who are living on aromatase inhibitors in the aftermath of an estrogen positive breast cancer diagnosis. Where we love this grant. We love, obviously, the program. This program came about because we listened to those who were really struggling. Not everybody, certainly not everybody, but there were those across the spectrum of some difficulties, side effects, symptoms of estrogen depletion, and they were looking for information, education. We designed this program for those that are on aromatase inhibitor. We had letters of support from Dr. Alyssa Houston and Dr. Farhan Imran, among others. It's been a very successful program. The next one begins in March. It's the 4 Saturdays in March from 9 to 11 a.m. I can't say enough about this program. We think it is unique in our country. We did a lot of research. We had Dr. Candace Lucas at the coalition for a year doing a review of the literature and helping us find studies and intervention programs that we thought might be helpful. And overwhelmingly, we are very pleased with the results that folks are experiencing. This is a 4-week series, as I said. It focuses on how and why the drug actually works, what kinds of side effects are most complained about, and ways to actually mitigate some of those things. So we have a occupational therapist, we have nurse practitioner, we have a retired oncology social worker, we have a physician who specializes in diet and nutrition. It's a total package, and we welcome you to participate. So if you have not taken the program and are on an aromatase inhibitor, consider it. We have also welcomed those who are on tamoxifen. Some of those folks have similar complaints for different reasons, but the bottom line is we don't turn anyone away. And I want to introduce Christina Thompson. She is our Associate Director here at the Breast Cancer Coalition, and she oversees our programs and our advocacy effort. And Christina, I'll let you take it the rest of the way. Thank you.
Wonderful. Thank you so much, Holly, and welcome everyone. I just have a few announcements as we get started here. So Tuesday, March 7th, NIAID's Oncology Rowing is holding a Taste of Rowing registration. And that's going to be from 6 to 7:30 at the Genesee Waterways Central Boathouse on Elmwood Avenue. If Allie would be so kind as to put in the registration link, it is required. This is an introductory evening where you will learn more about NIAIDs and rowing. You'll meet some of the crew, tour the boathouse, and experience the feel of rowing using a rowing machine. Of course, free of charge. This is something that our next program up for discussion is the Empire State Hematology and Oncology Society presenting a review of the San Antonio Breast Cancer Symposium. It's Saturday, March 4th at Del Lago Resort in Waterloo. The event will be the first review of the Breast Cancer Symposium. You're welcome to participate in interactive sessions that are led by some of the nation's leading breast cancer experts, including Dr. Ruth O'Regan here with us this evening. Sessions will be led by providers as well from Roswell, Upstate Medical, and URMC. And Allie has the registration that she'll put in the chat if you want to learn more or go ahead and register for it. I have a special note from Meredith Upman, our Director of Special Events. Our walk and run is back this year with a new name, Pink and Teal Challenge. Join us May 13th, a Saturday at Monroe Community College. Our event includes our 5K women only run, as well as a family-friendly all-inclusive walk. There's also a virtual component welcoming participation from anywhere around the world. If you register by April 10th using the link that Allie just put into the chat, you'll be guaranteed a t-shirt. So a few programs coming up at the coalition itself. Mindfulness and meditation with Rick Lynch begins on Saturday mornings at 10 a.m. on Zoom. It's March 4th, and you can contact Allie at bccr.org to register. Tai Chi with Jean Sika will be Tuesdays starting March 3rd on Zoom. We also have a few spots left for the program that Holly was speaking about, Surviving and Thriving on Aromatase Inhibitors. That program is going to be virtual Saturdays in March from 9 until 11 a.m. And it's a 4-week program meant to help those prescribed an aromatase inhibitor or tamoxifen as part of their treatment plan who find themselves struggling with the side effect of estrogen depletion in their bodies. So Allie can throw a link in here that takes you to our website, talks more about the program. And if you'd like to register for it, we do have just a couple spots left and you can register with her. So about tonight's event, please note that at any point that you leave the webinar this evening, a brief survey will pop up from Zoom. We really ask you, it's just a few questions. Please take a couple minutes to answer these questions. Our staff takes all of these responses into consideration as we put together programming. One example of utilizing the feedback we get from our surveys is that there was a reminder email sent out by Zoom tonight, 1 hour before the program started, and in there was also a link to the slides for Dr. O'Regan's presentation tonight. Allie, if you don't mind putting the link in one more time, a lot of folks have requested that they have access to those slides before the presentation begins. So now I'd love to introduce our presenter for this evening, Dr. Ruth O'Regan. She's the Medical Chair of Medicine and Charles A. Dewey Professor at the University of Rochester. She also serves as Physician-in-Chief at Strong Memorial Hospital and is the Associate Director of Education and Mentoring at the Wilmot Cancer Institute at the University of Rochester. Dr. O'Regan was part of the Breast Cancer Coalition's Advanced Breast Cancer Seminar in 2021 and presented on accessing clinical trials. So this evening, our chat feature is open for questions. Thanks to all those who submitted questions in advance. We will facilitate a Q&A following today's presentation. And Dr. O'Regan, I will turn things over to you.
Christine, I just want to make sure you can hear me okay, because
Yes.
my headphones stopped working. Okay, perfect.
Absolutely.
All right. Well, thank you so much, Christina and Holly, for a very kind introduction. And I'm just going to echo one thing that Holly said. You know, we are so honored to work with any of you as advocates on our grants. You know, more and more of the grant mechanisms are actually I wouldn't say demanded, but want us to have advocates involved. And I think your input is so crucial in terms of what we do, because sometimes we think something's a great idea, but no, it's not really a great idea. So we stand corrected. So with that, let me just go ahead and share my screen here.
Let's see here. Hopefully that looks good. Okay, great. Right, I'm just going to collapse you up here. So, so Christina asked me to talk a little bit about hormone receptor positive breast cancer. And as probably most of you know, this is the most common type of breast cancer that we see. It makes up about two-thirds of the breast cancers that we see. It can be estrogen receptor positive and progesterone receptor positive. And actually, just to that end, you know, we always think about estrogen receptor. Progesterone receptor is really a gene that estrogen receptor regulates, and that's why very often you see them expressed together. And just to remember that we're talking about hormone receptor positive, HER2 negative breast cancer mainly tonight, but you know, obviously hormone receptor positive breast cancers can also be HER2 positive, and that's really a very different treatment approach. So I suspect many of you have seen this before. This is really very pivotal data that came out, I think, in around 2020 or so. And it basically told us what we kind of knew previously, and that is that not all breast cancers are the same. So what they did in this was they took a group of cancers, they looked at these 50 genes, and what they found was that the breast cancers clustered into these 4 or 5 different groups. So these look kind of crazy, these heat maps here, but when you look at them, what the red means is that a gene is overexpressed, and where you see green, it means a gene is underexpressed. And, you know, it's like apples and apples and oranges and oranges, they cluster into these different groups. So we have the HER2 positive subtype, which is in purple. The red is the basal-like, which is really kind of like the triple negative breast cancers, which are the ones that don't express any of the 3 receptors that we're talking about. But then what was very important about this data is they identified 2 different estrogen receptor positive subtypes, one that's called a luminal subtype A and one that's called a luminal subtype B. The dark blue is the luminal A's, and the kind of lighter blue is the luminal B's. And when you look over at the right-hand part of this slide, what we're looking at on the upper curve is time to distant recurrence. So in other words, time until the patients developed a recurrence outside the breast. And at the bottom, we're looking at overall survival. And some of the stuff here is kind of what we've seen before. Triple negative has a high recurrence rate, but it's rare to have a recurrence after 5 years. These HER2 positive curves are before we had trastuzumab or Herceptin, so they look completely different now. But just to point out the estrogen receptor subtype shown here, what you can see clearly is that the dark blue, which is the luminal A, have really a pretty low rate of distant recurrence compared to the luminal B cancers. And it's even more striking when you look at the survival curves on the bottom. You can see the luminal patients with luminal A really have a quite favorable survival, but the luminal B cancers, you can see those patients, their outcome in terms of survival is really no better than the triple negative breast cancers. And again, this is old data, so obviously we're going to talk about some of the new therapies that we have today. So you know, these curves are changing pretty much every year, I think. Now, one of the questions is, why is the outcome so much less favorable for luminal Bs versus luminal As? Well, I think part of it is that luminal Bs tend to be what we call resistant to endocrine therapy. So what that basically means is that the endocrine agents that Holly was talking about, the aromatase inhibitors and tamoxifen, just don't work very well in these cancers. In contrast to the luminal A cancers, they really appear to benefit a lot from endocrine therapy, as you can see shown on this curve. But there's probably a lot more to it than that. And obviously, even if you look at the luminal A curves, we'd rather see the rate of distant recurrence much lower than what we're seeing here. So a lot of work to be done in terms of new agents. Now, I'm going to talk first of all just briefly about metastatic estrogen receptor positive breast cancer. Reason being that everything that we use in the early stage setting initially was used in patients with metastatic disease. So we're going to talk about the endocrine agents, which were the first ones to get approved. So tamoxifen was approved way back in the 1970s up to the 80s, initially for metastatic disease and then for early stage disease. And I think, as you know, it's now approved for ductal carcinoma in situ, and even actually for preventing breast cancer. Then quite a while later, the aromatase inhibitors were approved, and we'll talk about them actually in the metastatic setting and then in the early stage setting. Fulvestrant was initially approved in 2002. We then worked out that we weren't giving it correctly, so it was approved at what was referred to as a higher dose in 2012, and I'll talk more about these agents in a second. Then from 2012 onwards, we've had this kind of rapid approval of a lot of these other targeted agents, most of which actually just make the endocrine agents work better. So everolimus or Afinitor was approved for metastatic breast cancer in 2012. The CDK4/6 inhibitors, initially palbociclib, then ribociclib and abemaciclib, we'll talk about them, were all approved in 2015 to 2017. So pretty recently, as you can see. We'll talk a little bit about alpelisib, which is a PI3 kinase inhibitor, which was approved in 2012. And then just in the last few weeks, we had the first oral selective estrogen receptor downregulator approved. I'll explain what that is in a second. It's elasantrin, which is approved for patients who have pre-treated metastatic ER-positive breast cancer. So I just want to spend a minute or two on this slide, because this really talks about the endocrine agents that you all know about, and it's divided into different buckets, basically depending on how they work. So tamoxifen is what's called a selective estrogen receptor modulator, and what that means is that it actually affects the way the estrogen receptor functions within the breast cancer cell. So in order for the estrogen receptor to function, it has to basically latch on to another estrogen receptor, and tamoxifen prevents that happening. So what that means basically is that any estrogen that's made in our bodies can't get to breast cancer cells because the estrogen receptor is no longer a viable target. Now, the reason it's called a selective estrogen receptor modulator is because it acts as an anti-estrogen in the breast, in the brain, in other parts of the body, but it actually acts like estrogen in some other parts of the body, including on the uterus, which is why there's an increased risk of uterine cancer in postmenopausal women. But on the plus side of that, tamoxifen is actually quite effective in maintaining bone density because of these estrogenic properties. Trimethoprim is basically a derivative of tamoxifen. It is approved for metastatic disease. We don't use it very much, although sometimes I have used it in premenopausal patients who can't tolerate tamoxifen. It has the same mechanism of action. And then raloxifene is kind of an odd drug because it's the same class of drugs, tamoxifen and trimethoprim, but it really wasn't found to be very effective in treating breast cancer. But strangely enough, it is approved for preventing breast cancer, as tamoxifen is as well. And some of you may also know it's actually approved for maintaining bone density. So again, just to illustrate, these have kind of off-target effects, some of which are good and some of which are bad. Now, the aromatase inhibitors are anastrozole, letrozole, and exemestane. Anastrozole and letrozole are sister drugs. And let me just back up a second. The way these drugs work is when we're postmenopausal, we make estrogen in our body, in the adrenal glands, fatty tissue, muscle, by converting androgens, which are male hormones, into estrogen. And the enzyme that does that is called aromatase. So the aromatase inhibitors basically block that conversion of testosterone into estrogen, thereby markedly decreasing estrogen levels. So there's no estrogen for a breast cancer cell to feed off. So anastrozole and letrozole do that in a certain way. It's called non-competitive inhibition, whereas exemestane or aromasin is a suicide non-competitive blocker of the aromatase enzyme. Sorry, anastrozole and letrozole are competitive. Sorry, I got it the wrong way around. What does that mean? Well, in the early stage setting, all three drugs are the same. They're all the same in terms of efficacy and really in side effects as well. But in patients with metastatic disease, if somebody's had an anastrozole or letrozole, exemestane can be effective as a next line of treatment in those patients. So we call that being not cross-resistant. Fulvestrant, many of you have probably heard of this drug. So this is an estrogen receptor downregulator. So what it does is, again, just like tamoxifen, it affects the way the estrogen receptor latches onto another estrogen receptor, but it completely blocks this process. So it is very effective in preventing estrogen getting into cancer cells, but also, unlike tamoxifen, it doesn't have any of those estrogenic effects or estrogen-like effects that tamoxifen has. So it's actually a pretty safe drug. It's not associated with uterine cancer or any of the other kind of issues you see with tamoxifen. The downside of this drug is it has to be given as an intramuscular shot. It's a pretty large amount of fluid, so, or sorry, solution. So, you know, particularly because now we give it a higher dose, she actually have to get 2 shots. So some women do notice some injection site pain with this drug. And this, I'm mentioning this as a preamble to this, the elacestrant, or the oral SERD, or selective estrogen receptor downregulator, that we're going to talk about later on. Now, I also added in here a couple of other types of drugs. So this may sound very weird, but estrogen was used to treat estrogen receptor positive breast cancer before we had tamoxifen. If you look at lab studies, especially if you've been on an aromatase inhibitor, estrogen starts actually killing estrogen receptor positive breast cancer cells. So we don't really use it anymore, but it's something that certainly has been used in the past. The other ones that have been used are progestins. Magistral acetate is another fairly effective breast cancer drug. It's sometimes used to stimulate appetite now, but again, we don't use it very often. And then androgens have also been used to treat estrogen receptor positive metastatic breast cancer in the past. So that's kind of the agents that we have. We can talk about the side effects later on, but with the aromatase inhibitors, because they reduce estrogen levels to a very low level, you do get bone loss, I think, as many of you know, but this weird joint pain, which is really kind of unexplained and doesn't happen in all patients. But I will say that in premenopausal patients that we put into menopause with some of the agents we use, it's not uncommon for them to get a lot of joint pain as well. So it seems to be something to do with this decrease in estrogen levels. Now, the CDK4/6 inhibitors, I think many of you have probably heard of these drugs. Palbociclib is Ibrance, ribociclib is Kisqali, and abemaciclib is Verzenio, just they're the trade names. You can see the structure shown here. The palbociclib and ribociclib, because they can cause drops in white count, are given once a day for 3 weeks on with a week off. Abemaciclib causes less drops in blood counts, so it's given continuously twice a day. It does cause some diarrhea, though, so it can be a bit of a tough drug with regard to that. Now, how do these drugs work? Well, what they do is, as we know, cancer cells are cancer cells because they multiply more quickly than normal cells. What these drugs do is they go in and block a protein that basically causes cancer cells to multiply. Now, strangely enough, although abemaciclib has some single agent activity, they really have pretty modest single agent activity and really haven't been shown to be that effective in any other cancer apart from estrogen receptor positive breast cancer. So it's kind of one of the mysteries out there. We don't really understand why these drugs really work best when they're given with endocrine agents, either aromatase inhibitors or fulvestrant. And the only biomarker that we have for these drugs so far is the estrogen receptor. So there's a lot of questions in terms of their mechanism of action and, you know, looking for biomarkers to really determine which patients are really going to benefit. And this is going to be more important when we talk about the early stage setting. So these drugs have totally revolutionized the treatment of metastatic ER-positive breast cancer. So these are a series of randomized trials in which patients with newly diagnosed metastatic breast cancer that hadn't been treated for metastatic disease were randomized to receive endocrine therapy. In most cases, this was either an anastrozole or letrozole alone or with one of the CDK4/6 inhibitors. So the Paloma trials used palbociclib, the Mona Lisa trials used ribociclib, and the Monarch trial used abemaciclib. Don't ask me where these names come from, particularly the Mona Lisa. It's very odd, but and the first thing that we looked at was what's called progression-free survival, which is a marker of how long a patient's disease is controlled for. And so what you can see that essentially, just to cut to the quick here with these, the adding in these CDK4/6 inhibitors doubled the length of time that patients had their disease controlled. So what we were looking at before was the median time that a patient would have their disease controlled is 1 year. Now it went up to 2 years. Now I say that with caution because how much benefit a patient gets from these drugs depends on a number of factors. For example, how long it is since they were diagnosed, if they've just been on treatment in the early stage setting, where their metastatic disease is. There's a lot of components that fit into this. But if you look, and I think I put this in here, I'll show you the median survival in a second, now that we have these agents. This is looking at survival on the right-hand part of the slide. And the Mona Lisa trials, of which there's 3, all use ribociclib, all show a significant improvement in survival for adding in the CDK4/6 inhibitor with the endocrine therapy. The Monarch 3 study, which is with abemaciclib, showed a very meaningful improvement in survival, but it wasn't quite statistically significant when they presented it last time. And for some really unexplained reason, the trials with palbociclib didn't show a significant improvement in overall survival. The reason I say it's surprising, we don't really understand it, is because the impact on disease control was incredibly similar between the 3 agents. So we don't really understand the survival data, but I will say that this has led a lot of us to use either ribociclib or abemaciclib in preference, because obviously we want patients to live as long as possible. So this is the data with ribociclib. So in this study, patients with newly diagnosed metastatic breast cancer received letrozole with or without ribociclib. I showed you just, this is this trial here, the 9-month improvement in progression-free survival. Here's the overall survival. And what you can see here is that the median overall survival in this trial is over 5 years. That's at 64 months when they got ribociclib. Actually, in the control arm, the median overall survival was 51 months, which was actually better than what we've seen before. But I think the key thing here is that, you know, we can now tell patients that the median amount of time that you're going to be alive is more than 5 years, and it could be longer than that. So I think these drugs really are achieving the goal of changing metastatic disease into a chronic disease. And because some of the other agents we're going to talk about today are available now, we would expect these survival curves to improve even more going forward. This is just from the palbociclib trial. The curves here are very superimposed, and you can see there's really no benefit for the CDK4/6 inhibitor, which we, again, don't really understand. And lastly, this is with abemaciclib. Again, what you see here is that in the abemaciclib arm, the median overall survival is 67 months. So even longer on the ribociclib trial, but it wasn't quite statistically significant. This follow-up, this is not the final analysis of this trial. So again, more data showing that these patients are really living a very long time. Just very quickly to mention premenopausal patients. For premenopausal patients, when they develop if they develop metastatic disease, the first thing we do is we render them postmenopausal, either by giving them Lupron or one of those type of agents, or by taking their ovaries out. And then after that, you kind of treat them the same way you would have with the postmenopausal patient. This is a trial with ribociclib that was specifically for pre or perimenopausal women with newly diagnosed metastatic disease. They got random. They all received grazerolin to shut off their ovaries, received endocrine therapy with either placebo or ribociclib. Again, we saw a progression-free survival that was doubled with the use of the CDK4/6 inhibitor. And here's the overall survival shown here. And at this endpoint, it was significantly better with ribociclib, but actually the median overall survival had not been reached in that arm. So again, just showing that these drugs, even in younger women, are really highly effective and really have dramatically improved outcome for patients with metastatic disease. Now, I want just briefly to mention one of the other things that is done routinely in metastatic disease. So and just briefly explain genetics versus genomics. So what is the difference between genetics and genomics? So genetics is focused on what we call germline mutations. So what are germline mutations? They're mutations that predispose you to developing breast cancer. So I'm sure many of you have had genetic testing. It's just a blood test that's sent off. An example of these drugs are BRCA mutations or CHEK2 mutations. And of course, they're very important anyway to know about this, because particularly the BRCA genes predisposed to both breast and ovarian cancer. But we now actually have a treatment called PARP inhibitors that we can use for patients in the metastatic disease or the early stage disease if they have a BRCA mutation and a HER2 negative breast cancer. Genomics, on the other hand, looks at somatic mutations that are acquired by cancers. Now, they can be the same as the germline mutations. So in a patient who's got a BRCA mutation, their breast tumor is also going to be deficient in BRCA. But there are other ones that occur in the tumors that are not germline mutations. So we know that we can detect these these somatic mutations by using genomics or looking at gene expression, like I showed you on the first slide on tumors, but now we can actually do it from the blood as well. And that's called circulating or liquid biopsies, or you can also hear circulating DNA. And the somatic mutations that we look for with genomics are very important because they actually help us select specific treatments for patients. So sorry, but this is kind of a busy slide, but just to explain what's going on here. So this is basically looking at a set of estrogen receptor positive breast cancers from patients. And what they did was they compared the expression of certain genes at the time the patients were diagnosed with early stage disease to when they developed metastatic disease. And I just want to highlight on the right-hand part of this slide, what we're seeing here in blue are mutations that are present both in the early stage cancer and the metastatic cancer. And one of these is very important. It's called the PI3 kinase mutation, which I'll talk about in a second. That's present in about 40% of estrogen receptor positive breast cancers. The ones that should be in red, but kind of are red with the yellow center, are also very important because they're what we call acquired mutations. So they're not present at the time of diagnosis. They're acquired as the cancer gets exposed to treatment. So a couple of them are very important. ESR1, these are mutations of the estrogen receptor, which I'll talk about briefly. But also, very interestingly, you can also acquire mutations of ERBB2. ERBB2 is the same as HER2. So there's been some trials that have taken patients who have these acquired HER2 mutations and treated them with a HER2 oral agent called neratinib. And actually, it's been shown to be effective in patients where they've acquired in patients whose tumors have acquired this mutation. So it's just very important to do this. So when a patient develops metastatic disease, we always do a biopsy. That should be checked for genomics, or blood should be sent for genomics. So it can really help you make decisions for your patients. So the ESR1 mutations I mentioned are essentially mutations in the estrogen receptor. This graph on the left-hand part of the slide basically shows these different mutations in breast cancer, and it's comparing the primary cancer with the metastatic cancer. And what you can see here is when you look at the ESR1 mutations, they're really never present in primary cancers, but they're present at a pretty high rate in metastatic cancers. Here it says 20%, it's actually much higher than that, because if you look with liquid biopsies, you see a much higher rate in 35 to 40% of patients. These mutations all occur in the part of the estrogen receptor that's targeted by endocrine agents. So the reason that's important is because these ESR1 mutations could be associated with resistance to endocrine therapy. And in fact, they are. So this is a study, basically, a trial in which patients with metastatic disease got either exemestane or fulvestrant. What they found was that in patients who had ESR1 mutant cancers, both groups of patients had a pretty short disease control, but it was particularly short in patients who got an aromatase inhibitor compared to fulvestrant, versus in the wild type group. On the right-hand part of the slide, you can see the patients are doing equally the same. I will say we now have data saying that actually even fulvestrant isn't that effective in cancers with the ESR1 mutations. But the good news is that the CDK4/6 inhibitors work, and the new drug that we're going to talk about, emacentrant, also appears to work in these ESR1 mutant cancers. So with that, so some of you may have heard about these drugs, these oral selective estrogen receptor down regulators. So they're kind of like fulvestrant that I talked about, but they're given by mouth, which is much better, because then you know that the actual drug level in the blood is going to be consistent. There is multiple of them being developed out there, and this is just across a number. I'm going to talk about the Emerald trial in a second, but this is just a snapshot of a couple of these trials. And the bottom line is, overall, these are all patients who've had prior treatment in the metastatic setting. So it's not like I was showing with the CDK4/6 inhibitors, but overall, they have fairly modest disease control, 4 months up to 6 months. But across the board, they all seem to be a little bit more effective in cancers that have ESR1 mutations. So the Emerald trial is shown here. So this is metastatic breast cancer, estrogen receptor positive. Patients had to have received 1 or 2 lines of endocrine therapy for metastatic disease and had to have received a CDK4/6 inhibitor and could have received a line of chemotherapy. And they were randomized to elacestrant, which is the oral SERD, or to whatever we wanted to give them, endocrine agent. So here's the progression-free survival shown here. So you can see it was improved from 2 months up to almost 3 months with the elacestrant. I did warn you that it was fairly modest. Now, these numbers look very low, and the reason for this is that these patients really have endocrine-resistant disease. So this is actually better than it actually looks. Now, and then looking at patients whose tumors had an ESR1 mutation, you can see the standard of care was about 2 months up to almost 4 months with elacestrant, as you can see shown here. And this was just basically comparing it to fulvestrant. And you can see whether you had patients who had all patients you looked at, elacestrant was better. In patients whose tumors had mutant ESR1, you can see that again, it was better than fulvestrant shown here. And the reason this is important is because this is where this drug is approved for pre-treated metastatic breast cancer that has ESR1 mutations. Now, this was just presented at San Antonio, and what they did here was they looked to see, if the benefit of the elacestrant correlated with the length of time the patient had been on a CDK4/6 inhibitor, and it actually did. So in patients who received 6 months or less of a CDK4/6 inhibitor, the difference on the left-hand part of the slide for elacestrant is, it's still, the curves are separated, but just to show you here that as patients have taken longer durations of CDK4/6 inhibitors, 12 months or 18 months, which is the norm actually, because most patients do stay on these drugs for about 2 years, the curves separate much wider in favor of the oral SERD, as you can see. In terms of side effects, pretty well tolerated. There's some GI toxicity with these drugs, but overall they're pretty well tolerated. And again, no need for the injections that you get with fulvestrant. So I think these drugs will be even more interesting when we get into the earlier line setting. There's trials looking at them with CDK4/6 inhibitors. I think will be very interesting. So just briefly, just to talk about a couple of the other agents we use in metastatic disease. So this curve just basically, as we talked about earlier, or maybe we didn't actually, but one of the problems with ER positive metastatic disease is that eventually the cancer cells become resistant to endocrine therapy. So it's kind of like those super bacteria that become resistant to all antibiotics. So it's that kind of idea. And this has been studied a lot, but one of the things that we've seen is that what happens is that rather than being driven by the estrogen receptor, what happens is the cancer cell starts getting driven by these other proteins in the cell. The EGFR, HER2, PI3 kinase, AKT, mTOR pathway is very important. The reason for highlighting that is that we have drugs that can target this pathway. And as I'll show you in a second, by blocking these pathways, you're able to resensitize cancer cells to endocrine therapy. So everolimus is what's called an mTOR inhibitor. So it basically targets the cancer cell right down in the nucleus, very close to the estrogen receptor. So these are a couple of trials in patients who had endocrine refractory disease, where the everolimus was added in with an endocrine therapy, either tamoxifen on the top or exemestane, the aromatase inhibitor, on the bottom. And, pretty impressive separation of the curves in favor of everolimus with disease control in this endocrine refractory setting of 9 to almost 11 months, as you can see shown here. So this is a drug that we do use in patients. It can cause mouth sores and some lung toxicity, but it's generally pretty well tolerated. And then the last thing is on the metastatic side I wanted to mention was, I mentioned earlier the PI3 kinase mutations, which are present in about 40% of estrogen receptor positive breast cancers. They were present in the primary and the metastatic cancer. There's been a number of agents called PI3 kinase inhibitors that have been basically developed to target these ER positive breast cancers that have these PIK3CA mutations. The one that has been approved is with alpelisib, which is, as I said, a PI3 kinase inhibitor. And if you just look at the top part of this trial, what they did was they targeted patients who'd had prior treatment for metastatic disease, had a known PI3 kinase mutation, and randomized them to either endocrine therapy with fulvestrant alone or fulvestrant with the PI3 kinase inhibitor alpelisib. There was another arm in which patients whose tumors did not have PIK3CA mutations were enrolled. They were treated either with the alpelisib and fulvestrant or placebo for fulvestrant. That was a negative trial, so I'm not going to talk about that anymore. But here are the results in the patients whose tumors had PIK3CA mutations. You can see the curves again. This again is the endocrine refractory setting, 6 months in the control arm versus 11 months in the alpelisib fulvestrant arm, as you can see. This is a pretty toxic drug to take, I have to say. It can cause a lot of high blood sugars and rashes and things like that, but it is certainly effective. And there's a lot of interest in looking for agents that target this particular protein that have less toxicity. So now I'm going to move on to the early stage setting, and I put in a couple of summary slides to start, because I don't think we have time to talk about this whole subject. So I've picked out a few things. So I think for patients with early stage ER-positive breast cancer, I think, as you all know, we use genomic assays to make treatment decisions. And the ones that are used most commonly, or at least the one that's used most commonly, is the 21 gene recurrence score, the oncotype. There also is MammaPrint, which is the 70 gene signature. And both of those are used to determine whether patients need chemotherapy or not. Because one of the things we know about ER-positive early stage breast cancer is that only a subset of patients actually benefit from chemotherapy. And I don't want to give any patient chemotherapy if they're not going to benefit from it. So these really revolutionized our treatment, because before we had these genomic assays, we were giving everybody chemotherapy, even though they probably didn't benefit. So for patients with node-negative disease, and actually also patients with N1 disease, which is 1 to 3 positive lymph nodes, if you use the oncotype assay, what it shows is that there's zero benefit of chemotherapy up to a recurrence score of 25. What does that mean? That means that we've saved thousands and thousands of postmenopausal women chemotherapy that they're not going to benefit from. Unfortunately, in premenopausal patients, it's a little bit more tricky. In node-negative disease, there's no benefit up to a score of 16. And then 16 to 25, there's some benefit. So it's always discuss it with the patients and look at other factors in the tumor as well. With patients with N1 disease, again, patients under the age of 50 all appear to gain some benefit from chemotherapy, even with low oncotype scores, which I think is very disappointing. And, we can talk about that later. Is there a way of avoiding that by other things like using ovarian suppression? And just to be fair, the 70 gene signature was looked at in the MINDAC study, and that wasn't designed in the same way that the oncotype studies were designed. But again, if you have a low MammaPrint score, particularly if everything else looks favorable on the cancer, patients do just fine with endocrine therapy alone. So for postmenopausal women, there's not much new here, but I know there was a question in the chat that we can talk about later as well. But so there really has been no new endocrine therapy approvals since the adjuvant aromatase inhibitor trials, and they were a long time ago. But what they showed was that the use of an aromatase inhibitor alone or sequenced after tamoxifen is associated with an improved outcome compared to tamoxifen alone, though it is modest, and at least the studies with anastrozole did not show survival difference. So that's why if I have a patient who's having a tough time with aromatase inhibitors, I'm very comfortable putting them on tamoxifen, because I think the difference is pretty modest. And it's amazing to me that some patients just tolerate tamoxifen much better. The addition of bone-directed agents further improves outcomes. So we do tend to use Zometa and denosumab to help with bone density in patients on aromatase inhibitors, but they've also been shown to actually improve outcome. The remaining questions, we can talk about duration of therapy later on. It's very controversial. The standard it was always to give 5 years. The standard with tamoxifen now is 10 years. With the aromatase inhibitors, continuing beyond 5 years is a little confusing, because even though patients do better if you give 10 years, it's really by preventing other breast cancers rather than actually preventing the initial breast cancer from recurring. So we can certainly talk about that, because I did see a question related to that. Addition of new agents, I'll talk about the CDK4/6 inhibitors in a second. And I think, as Holly was talking about, toxicity is an issue. with these agents, since you have to take them for a very long time, and this can lead to issues with adherence. So my one word here is it's very important that you take these treatments, because we know that they do significantly reduce the risk of recurrence and improve survival. So it doesn't matter which one you take, I think, in my opinion, as long as you're taking one of them, because the difference is fairly modest. Now, just to talk about premenopausal patients. So premenopausal patients, the standard of care up until this trial came out was tamoxifen. Now, tamoxifen is very effective in premenopausal patients, which in some ways seems a little bit strange, because obviously premenopausal patients have much higher levels of estrogen compared to postmenopausal patients. However, when you think about it, when I explained how tamoxifen works, it probably doesn't matter what the level of estrogen expression, the amount of circulating estrogen is, because it's actually acting directly on the estrogen receptor. Now, why don't we use aromatase inhibitors in premenopausal women? Well, first of all, they don't work. And one of the reasons they don't work is because of the fact that if you give an aromatase inhibitor, what happens initially to a premenopausal patient is initially you do get a little bit of a drop in estrogen, but that low estrogen level basically sends a message back up to the pituitary gland. The pituitary starts pumping out these hormones that basically cause the ovaries to get overstimulated and basically bring the estrogen levels right back up. So they just don't work, and they can cause a lot of ovarian cysts. And this is why they're actually used as part of a lot of fertility treatments, because of this, of how their mechanism of action. So one of the things that was out there is, well, tamoxifen works, but it appears that, that basically dropping estrogen levels in premenopausal patients may be an effective way of treating premenopausal breast cancer. So the soft and text studies are shown here. Let me talk about the bottom one for a second, because it makes a little bit more sense. So SOFT stands for Suppression of Ovarian Function Trial. And this took premenopausal patients who either had not received chemotherapy or remained premenopausal after chemotherapy, because I think, as you know, chemotherapy can temporarily stop the ovaries functioning. And it was addressing the question of what does ovarian suppression add to tamoxifen? And then also, could we substitute exemestane, the aromatase inhibitor, for tamoxifen? So 3,000 patients enrolled in the study, and they received either tamoxifen for 5 years, tamoxifen plus ovarian suppression for 5 years, or exemestane plus ovarian suppression for 5 years. We have a median follow-up of 12 years in this trial, so very long follow-up. The other trial is the TEX study, which is tamoxifen exemestane trial. Again, premenopausal patients could have received chemotherapy or not. They all received ovarian suppression, and that's given by a shot, as it was in the SOFT study. And they got randomized to tamoxifen or to exemestane. So you can see here that one of the things that was done was the results in the TEX trial were basically combined with the two arms of the SOFT trial that are in red and blue, that I'll show you. So just looking, I'm sorry, this just shows you the different comparisons. So first question was, what about adding ovarian suppression in with tamoxifen compared to tamoxifen alone? What about using an aromatase inhibitor with ovarian suppression versus tamoxifen plus ovarian suppression? They were the questions. So here are the results shown here, and this is the SOFT study again with a long follow-up. And I know the curves look very close together, but there are some differences. So looking at distant recurrence-free interval, which is how long this is looking at metastasis outside the breast. You can see it was 85% for tamoxifen alone, 86% for tamoxifen plus ovarian suppression, and 88% for exemestane. So the patients who got the exemestane ovarian suppression did better. Looking at overall survival, again, it was better for the patients who got ovarian suppression, whether it was tamoxifen or exemestane. They did better than patients who got tamoxifen, and this is looking at overall survival. And this is just the same data with the TEX study, looking at distant mets shown here, again, showing a benefit for exemestane compared to tamoxifen in patients who got ovarian suppression, and a slight benefit in in overall survival with exemestane. Let me see. Sorry. Right. So one of the things that was very interesting about the SOFT study is that, remember I mentioned in the beginning that patients could have got chemotherapy or not. Well, they analyzed the data based on patients, whether they got chemotherapy or not, and there were big differences. So what we're looking at here is the soft study in women who did not get chemotherapy. So what that would probably mean is that these would be women who had pretty lower risk cancers. So less likely to have node positive cancers, lower grade cancers. We didn't use, they didn't use the oncotype test, but lower, let's say perhaps lower oncotype scores. And what you can see here is that there's no difference really between the curves here. I mean, you have to trust me on that. There's no significant difference. So patients did pretty well, whether they just got tamoxifen, they actually did very well. You can see that at 12 years, only about 4% of patients have actually had a distant recurrence, but no significant difference in favor of ovarian suppression. Likewise, survival is very positive, as you can see shown here. Less than 5% of patients 95% of patients, 96% of patients are alive, as you can see, but no difference between the treatment arms. Now, if you contrast to the patients who had high risk enough cancer to get chemotherapy, you actually see meaningful differences. And the bottom line is the winner here is the exemestane plus ovarian suppression. It's a little better than tamoxifen plus ovarian suppression, but both of those arms are better than tamoxifen alone. And looking at overall survival shown here, 83, 84% if you get ovarian suppression versus only 79% if you take tamoxifen. So again, these are patients with higher risk cancers that all got chemotherapy. And the same data with the TEC study. This is patients who got chemotherapy. And you can see here that there's the difference in favor of using the aromatase inhibitor is more striking in the TEC study compared to the soft. Sorry, just combine the two studies. The same message: if you get an aromatase inhibitor with ovarian suppression, patients do better than tamoxifen plus ovarian suppression, and likewise the same thing for overall survival. So I think the guidelines. Oh, sorry, I didn't realize I put that in. Actually, sorry. One second. Let me just go back here for a second. So the bottom line here is that we have a choice in premenopausal patients. We can give them just tamoxifen, or we can give them ovarian suppression with an aromatase inhibitor. The issue here is which patients need the ovarian suppression, because it is toxic. It does impact adherence, and we don't honestly know what the long-term effects are. So I think having a biomarker to determine which patients really need ovarian suppression is crucial. And we actually presented some data with a different genomic assay called the Breast Cancer Index at San Antonio, which appears to be able to predict which patients benefit from ovarian suppression. Needs to be validated, but hopefully we'll get an answer from that in the near future. So this is basically summarizing, which I didn't realize I put in here, it was one of the questions. This is about extending adjuvant therapy. So the ASCO guidelines do not recommend extending adjuvant endocrine therapy for all patients with node-negative disease. And they recommend looking at things like age, the risk of recurrence, how patients are tolerating the drug. The breast cancer index, which I just mentioned, can be used to help make a decision about whether to continue adjuvant therapy beyond 5 years. It's a little nuances with that data, but it is available, and you can certainly ask your oncologist about that. There's currently no indication to extend endocrine therapy beyond 10 years. And as I kind of alluded to, if you think about an aromatase inhibitor, a lot of what it does after 5 years is prevents you developing a second breast cancer. Now we're getting to the end here because I know I've been talking probably too long. So what about adding in new agents? Obviously a very important question. So I just showed you really exciting data with the CDK4/6 inhibitors. So as I mentioned in one of the earlier slides, everything that we do in the metastatic setting, we ultimately try and translate into the early stage setting. And we have done this. So these are the trials that are looking at the target agents that we talked about in the metastatic setting in the early stage setting. So we have 2 trials with palbociclib, a trial with abemaciclib, a trial with ribociclib, which is not reported yet. And then I didn't put any slides in about this trial, the SWOG study at the bottom here, which looked at using the mTOR inhibitor the mTOR inhibitor everolimus for a year And in all these trials, the standard arm was endocrine therapy alone, and the investigation arm was endocrine therapy with the targeted agent. This SWOG study was not a positive study. It was just presented. However, interestingly, the mTOR inhibitor appeared to be effective in premenopausal patients, but unfortunately, the number was too small to kind of make any definitive conclusions. So I'm just going to really focus on the MONARCH study because this drug abemaciclib is approved in the early stage setting. So all of these CDK4/6 inhibitor early stage trials recruited patients that were felt to have very high risk of recurrence. So the MONARCH-E trial took patients with hormone receptor positive, HER2 negative, node positive, high risk early stage breast cancer, and essentially randomized them to either standard of care after they had their chemotherapy, either pre-op or post-op, and randomized them to either standard of care endocrine therapy alone or with abemaciclib, which, as I mentioned, is given twice a day. And it was given for 2 years. You can see this is a large trial, 5,600 patients. They did have a couple of other nuances in terms of inclusion, which I'm not going to go into, but basically, all these patients had, either a lot of lymph nodes positive, or if they had 1 to 3 positive lymph nodes, they had high-grade cancers or very large tumors. So, definitely patients that were at high risk of recurrence. And here's the data from this trial. This is probably not the most recent follow-up, but what they found was after about 2 years, the curve starts splitting. And this is looking at all of our events, both in the breast and outside the breast. You can see the curve starts splitting in favor of the CDK4/6 inhibitor. And the data was just updated again, and the curves continue to separate such that the difference in favor of the CDK4/6 inhibitor now is about, I think, 7 or 8%. So it's actually pretty significant. This is looking at distant metastasis shown here. Again, you can see the curve separating in favor of the CDK4/6 inhibitor. And at this follow-up, the difference is about 4% to now like 6 or 7%, and again, statistically significant. So these are the side effects that were described. The diarrhea I mentioned before, some other GI toxicities, low blood counts, some serious things like clots, either to the lung or in the legs were seen as well. It is a tough drug to give, I have to say, I found, but I do think the data is very compelling that really for patients that have high-risk disease, we should definitely try and keep them on this drug. So it was approved in 2021 to abemaciclib with either tamoxifen or aromatase inhibitor for node positive, high risk, early stage breast cancer at high risk of recurrence. Now they also put in the Ki-67 score of greater than 20%. I'm not going to go into why they did that. I personally didn't agree with it, and I think people aren't really using this in their decision making, and the insurance companies are approving it without this. So I think we can kind of ignore that. So just one other study to mention, the PALACE study. So the PALACE study, again, took patients with high-risk early-stage ER-positive breast cancer, 5,600 patients. They had slightly lower risk cancers than the MONARCH-E study, and they were randomized to endocrine therapy alone or endocrine therapy with palbociclib for 2 years. And in contrast to the MONARCH-E study, this is looking at just all events. This is, and then on the left-hand side, on the right-hand side is distant recurrence. You can see those curves are completely superimposable. So for whatever reason, this drug was not effective in the early stage setting. There's another study that was done, also looking at palbociclib, that was also negative. So right now, the only one that's approved is abemaciclib. The ribociclib trial will probably be presented at ASCO. That's using 3 years of ribociclib. So that will be very interesting to see the results of that. So just to conclude on overall, for early stage breast cancer, we talked a little bit about genomic profiling and how it really has markedly decreased the use of chemotherapy, which is definitely a good thing. And I think now we very rarely give chemotherapy to patients over the age of 50 with ER-positive breast cancers. Ovarian suppression with an aromatase inhibitor should be considered for premenopausal patients with high-risk disease. How we define that, we still don't know. And as I just showed you, we now have a new agent, abemaciclib, that's approved for high-risk hormone receptor positive, node positive disease. In the metastatic setting, I think there's a lot of reasons to be incredibly hopeful. As I showed you, the CDK4/6 inhibitors are fairly new on the block. We now have elacestrant. There's a number of other agents in that group. And then there's a whole bunch of other agents that really look very promising. So I think we're now looking at median survivals of over 5 years. Hopefully we can push it out and out and out, and people just can live with this really as a chronic disease. So I'll shut up there, and I'm looking forward to any questions you may have, and I'll stop sharing here.
Wow, thank you very much, Dr. O'Regan. That's a lot of information. Very exciting that there's new things on the horizon, which is obviously huge for a lot of us just listening here tonight. So as you were going through your presentation, I was looking over some of the questions. I know some of the ones submitted to me have been answered, so I will definitely skip over those. So we didn't talk a whole lot about side effects of estrogen depletion in the body. So a few questions. One is regarding hair thinning. Will the condition be reversed after the 5 years of taking the medication? Another one was on tinnitus. Neuropathy, trigger fingers. What are your thoughts on those and stopping the medications to alleviate it?
Yeah, so I mean, the hair loss, that is, obviously it's something that we see with menopause. And, when you think about, I presume that they're talking about aromatase inhibitors specifically. I think you're taking your estrogen levels down to an even lower level. So it kind of makes sense that there could be some hair loss. It's not something that you see in every patient. And, sometimes it can be pretty mild. I see no reason why it shouldn't improve when you stop the drug, when the estrogen levels go back up a little bit. But it's not something that I think patients complain about a huge amount, but they definitely do report it for sure. The tinnitus, I'm not sure I've seen that, but I would say if it is due to the drug, the only way you're going to know is by stopping it. And I think that's, we end up stopping aromatase inhibitor in our patients all the time just to see if whatever side effect they have actually resolves. With the trigger fingers and the joint pain, I mean, it's baffling to me the kind of things you see in terms of joints with the aromatase inhibitors. And I think it can be nothing, it can be very mild, or it can be really debilitating. And I always, the first thing I do obviously is stop the drug, see if it gets better, which the joint pain typically gets better quite quickly actually. And then I will try another aromatase inhibitor. Sometimes that can be successful, but as I mentioned, going to tamoxifen is definitely an option as well, and that does not have the issue with the joint pain.
Mm-hmm.
So I think even though you'll hear a lot of people talking about the bone loss with the aromatase inhibitors, I think we all agree the most irritating side effect of these drugs is definitely the joint pain and the stuff it does to your joints. So yeah.
Okay, so on the topic of the bone loss, osteopenia, is there a study that shows how much bone loss there is if you've already got osteoporosis when you're prescribed the aromatase inhibitor?
Oh, good question. I don't know the answer to that. When the initial early stage trial with the aromatase inhibitors, I mean, they clearly showed that there was more bone loss with these drugs. But I don't know that they ever looked back at the baseline and kind of correlated that. Personally, for me, if somebody has really bad osteoporosis, I might consider starting them on tamoxifen, because tamoxifen actually does maintain bone density in postmenopausal women. And potentially, you could switch to an aromatase inhibitor later on, because we know from the adjuvant studies that were done that, if you gave a couple of years tamoxifen and then an aromatase inhibitor, that had the same benefit as just doing an aromatase inhibitor compared to tamoxifen. But I think the first thing to do, of course, is checking the bone density. We always do that before we start. But I think most of us would actually just kind of tell patients you're going to end up either on Zometa or denosumab as a routine. They're given it, 6 monthly. Zometa is given at the veins. Denosumab is given sub-Q. That's Xgeva, by the way. As I mentioned, and the reason I tend to use Zometa more is because the data with Zometa in terms of reducing the risk of breast cancer recurrence is actually, I think, a little stronger than it is with Xgeva. Because there was a meta-analysis done, and in patients who were postmenopausal, there was, a fairly significant decrease in recurrence rate, about 2 or 3% on top of what you were getting with the endocrine therapy. So I don't know if that really answers the question, but I think, you have to be very careful and keep monitoring the bone density as well in these patients. So I think, and a lot of people just start, Zometa out of the gate. I think that's very reasonable to do as well. Now, Zometa, of course, has its own issues. Typically the osteonecrosis of the jaw that's been described, it's quite rare. And I do think it's more commonly seen in patients who have metastatic disease where they're getting the drug more often. But of course, making sure that you see your dentist every 6 months is key when you're on these agents. But other than that, it's well tolerated. Some people get some bone pain the first time they get Zometa, but not subsequently. So,
okay. And regarding the dental work, someone who's extremely fearful for jaw necrosis, is there a substitute for Prolia?
yeah. So I think you can. So that's extreme. Sorry, I should have said pro. It's a weird drug because it's called a different name. It's different indication. So Prolia certainly would be an option, but of course Prolia also is associated with ONJ. It's fairly similar rate to Zometa, but I'm much less concerned about the osteonecrosis of the jaw in the early stage setting because you're getting the drug so less frequently. I think if somebody has poor dentition, it's a different matter. But I find most Americans have very good teeth, unlike from across the pond. So I think they typically see their dentist pretty often. So yes, Prolia is certainly an option as well. But I just tend to use Zometa just because the data is a little bit stronger for the breast cancer recurrence, and it's not just bones either. It's breast cancer recurrence overall. So.
Couple of questions about, are there particular AIs that are better for a type of breast cancer when we're talking ductal and lobular?
Yeah, that's a great question. I don't really think so. I think the question is more, there is some data saying that the aromatase inhibitors are better than tamoxifen in that setting. So these were subsets of some of the early adjuvant trials. I'm not aware, and there may be some data out there that one aromatase inhibitor is better than another in a lobular cancer. I don't know why one would be. I mean, they do have slightly different effects on estrogen. So letrozole is the most potent, so it reduces estrogen levels the most. But if you look at the trials that have been done in the early stage setting, the results in terms of efficacy are the same no matter which one you use. So I'm not aware of any data, but I think just to bring up lobular cancers, obviously they're almost always estrogen receptor positive, and they do appear to be pretty sensitive to endocrine therapy. So I think it's very important if you've a lobular cancer that you do try and take one of these agents. And I do think the aromatase inhibitors are a little bit better in that setting.
Okay. Let's see. What would you say drives the decision between tamoxifen versus ovarian suppression in AI for someone who's premenopausal and perimenopausal?
Yeah, so I kind of touched on this a little bit. So it's a little bit ambiguous because, it's very clear from the data I showed you that the patients who got chemotherapy were the ones that got the benefit from the ovarian suppression and the aromatase inhibitor. The patients who did not get chemotherapy, there was a very modest difference. The curves were very, very close together. But that's who makes the decision about whether a patient gets chemotherapy or not? The oncologist does, right? So that's not a really, hard and fast way of determining which patients really need ovarian suppression. So the way I would look at it is that if we feel that the cancer is high risk enough to justify chemotherapy, then we should talk to them about ovarian suppression. So what do I mean by that? What I mean is if they've got a node positive cancer, if it's high grade, if their Ki67, which is the proliferation marker, is high, or if they're high risk by a genomic assay like oncotype, I think they should get ovarian suppression. But I do think there's a fairly significant number of patients that have very low risk ER positive breast cancers that can get away just fine with tamoxifen. If you don't give them, think they need chemo, they're probably fine to get away with just tamoxifen. And as I mentioned as well, we just presented at San Antonio on the breast cancer index in this setting, and we were able to show that the breast cancer index is prognostic, so it can predict which patients, premenopausal patients, are going to have a recurrence, but also 2 of the genes that are in that assay also appear to be able to predict which patients actually really benefit from ovarian suppression. And Christina, just to go back to what you were saying, this is a really important question because you're talking about apples and oranges here. Tamoxifen is an incredibly well-tolerated drug in premenopausal patients with really none of the serious side effects that you see in postmenopausal women, versus a situation where you're giving ovarian suppression and then further wiping out all the estrogen by giving an aromatase inhibitor. We know what it does in postmenopausal women, but do we know what it does in women of that age who are going to have at least 5 years of this profound estrogen suppression? What are the long-term effects of that? And we just don't know. It's also very hard for especially younger women, you know, especially under the age of 35, very hard for them to tolerate. And the worst thing that could happen then is that they decide to take no endocrine therapy. So we really do need to work on a biomarker, because it's an incredibly important question.
That's a great point, because I did have a question coming up here about breast cancer index testing. So we can now cross that one off the list. Thank you.
Oh, I'll just say one thing about that. So breast cancer index, where that is used right now, is in determining who should get longer than 5 years of treatment. So that's its current, but this is hopefully, if it can be validated, this will be another indication for that assay. So.
Let's see. Are there any studies on the optimal length of time for endocrine therapy, specifically in HER2 positive as well as hormone positive breast cancer? Do you think there's a benefit on those who go longer than 5 years?
Oh, what a great question. So, you know, if you look at the studies that have been done, of course, there were patients that had ER positive, HER2 positive cancers on those studies. And but it's always such a small subset that I don't think they were ever really broken out on the studies that looked at longer durations of treatment. So I would say, first of all, I think, you know, HER2 positive cancers are very different, right, than HER2 negative cancers, because they are treated more aggressively with chemotherapy. And typically they have a pretty good prognosis overall. So I would say it depends. I think more and more we give preoperative chemotherapy to patients with HER2 positive breast cancer, whether they're ER positive or ER negative. If a patient has a complete response to that treatment, I would not go beyond 5 years, because we know that if you have a complete response to the treatment, your prognosis is really very good. If, however, you had somebody who, which is very uncommon now, that gets surgery first or doesn't have a complete response, you know, I think I would use the same kind of thinking that I would use for somebody who had a HER2 negative cancer. And actually, they did break, the breast cancer index did break out HER2 as well, but it's a small subset of patients. So there's not enough really to say that they're different from the HER2 negative cancers. Because I do think some of these ER positive, HER2 positive breast cancers can be driven by estrogen receptor more than HER2. So those ones might need longer treatment. And the other thing that's very interesting about these HER2 positive cancers is sometimes within a given cancer, some of the cells are more HER2 positive than others. So it's not uncommon to have a cancer where some of the cancer cells express high levels of HER2 and others don't. It's called heterogeneity. And it's more common when the cancers are ER positive. So the reason I mentioned that is you could imagine if you give a patient chemotherapy, you kill all the HER2 positive cells, you don't kill the HER2 negative cells. So there's a lot of nuances with this. But so I think I've talked a lot about this, but I think if somebody has a complete response to pre-op chemo, I would stop at 5 years. If they don't, I would use the same kind of thinking that I would use in HER2 negative cancers.
All right, so this question came up during your slides about some of the tests, the clinical trials, and this person was wondering if surgery was a consideration. Like if surgery choice had been a consideration, would you have the same outcomes on someone who had a lumpectomy versus a mastectomy?
Yeah, so it's a great question. So the data that we have, and some of it is somewhat older data, is that as long as you get radiation, the lumpectomy, the outcome for lumpectomy is the same as if you have a mastectomy. And that's true for, well, first of all, let me back up. The type of surgery you have really doesn't impact whether the cancer is going to come back in other parts of the body. That's why the chemotherapy and the endocrine therapy and the Herceptin and all those drugs are so important at preventing distant recurrences. For local recurrences, the studies have shown that a mastectomy versus a lumpectomy with radiation, the local recurrence rate is the same. So it's rare that we would say you should have a mastectomy. Now, there are some cases where we would. Inflammatory breast cancer, you have to have a mastectomy. Multifocal cancers, what means that when there's more than one in the breast, mastectomy, right? And then, of course, patients who have a BRCA mutation, you know, very often we'll recommend, you know, bilateral mastectomies to those patients. Apart from those instances, there really isn't any different difference. And, most breast surgeons actually really tend to encourage patients to think about lumpectomies rather than going to mastectomy, because there's no way back from that, right? And I think a lot of times I see patients and, of course, the default is I want mastectomy or bilateral mastectomies. Actually, now that we give so much pre-op chemo, particularly for HER2 positive disease, that actually gives people a chance to kind of think about it a little bit and really decide if that's what they want to do. There's nothing wrong with doing it, but you can't go back, right? So you want to make sure that you're happy with your decision. Doing a mastectomy, sometimes you could avoid radiation. If you end up having a positive lymph node, you're going to end up getting radiation, or if the cancer is large, you're going to end up getting radiation. If somebody really doesn't want radiation, and there are some patients that can't have radiation, for example, if you've got like lupus or scleroderma, you can't have radiation. So those kind of nuances. But overall, in answer to your question, it should be the same.
Yeah. Okay. Are side effects of increased cholesterol or LDLs common with exemestane or other AIs?
Another great question. I wouldn't say that you certainly see that. There's no question that you see that, because obviously estrogen is something that helps with that. I haven't seen it to be a huge issue, I have to say, but again, I don't think we really routinely check it. But and I haven't had a lot of patients coming in saying, I ended up on a statin since I started taking this. Conversely, though, I will say tamoxifen is beneficial for the lipid profile. So it's been shown to reduce LDL cholesterol and total cholesterol. So again, it makes sense because of its estrogenic effects. There's actually probably some data that we never quite determined conclusively that tamoxifen actually can reduce the risk of coronary artery disease. So I think if you're on an aromatase inhibitor, it's definitely worthwhile getting your lipids checked. Yeah.
Okay. So a question about premenopausal women: how long are you recommending to stay with Lupron and an AI?
I just would go by the study, which was 5 years. I really would be very leery of continuing ovarian suppression beyond 5 years. Now, sometimes women will choose to have their, oophorectomies. Again, it's not, I don't think there's data saying that that's something you absolutely have to do, but some people just feel more comfortable doing that. But for somebody who's been on Lupron for 5 years, I wouldn't continue it, because I think there's just no data.
Okay.
And as I mentioned in the talk, you got to stop the aromatase inhibitor then as well, because you can't give that to a patient who's got functioning ovaries, because they don't work.
Okay. So here's kind of a specific question, but if you have a recurrence after 4 years on an AI and you start a new treatment following mastectomy, would you take that for 5 years and then continue on from there if it's a recurrent case?
Yeah, I think at least 5 years. With a recurrence, you might be inclined to maybe push it out 10 years. Interestingly, there's the studies that there was a trial that showed that for ER positive breast cancer, if you have a local recurrence, patients don't benefit from more chemotherapy though. So you just go straight to endocrine therapy. So I would give 5 years, and I might think about giving it longer than 5 years, just because, again, it's the reason patients have local recurrence is because there's microscopic cells left behind. So just because you have one local recurrence doesn't mean that you're definitely going to have another one, but you might just be a little bit more leery in that situation.
Mm-hmm. What are you most excited or interested to see in the next 5 years or so from a drug medication standpoint?
Ooh, that's well, I think we're seeing so much, right? I mean, things are changing so much. So I think we're going to move to much more directed therapy. So I was talking about genomics and working out what genes are driving cancers. What you ideally want is a situation where a patient comes in and this gene is driving their cancer, so therefore we're going to give you this treatment. And I think there's a lot of interest in basically looking at that. And I am hopefully gave you a few examples of that tonight. So I think that's something I think we'll see more and more of. And I think the testing for genomics is much more, it's much easier than it was before. It's probably more accurate as well. So I think we've always been in this kind of thing, one size fits all. Everybody gets chemo, everybody gets this. There are probably patients out there that don't need endocrine therapy. So there's a big interest in breast oncology and de-escalating treatment as well. So actually giving less treatment. So I think that's something that I would be very excited about as well. Just one other very interesting group of drugs that we didn't talk about tonight are the antibody drug conjugates. So, these are molecules like Kadcyla and trastuzumab deruxtecan that was just approved. And what they basically are is you have a drug that has an antibody like Herceptin, one part of it, and it's joined to a chemotherapy. So what the antibody part does is it basically targets a protein on the cell and then deposits the chemotherapy directly into the cell. I think that's going to replace chemotherapy completely, because why would you take standard chemo when you have one that can get deposited right into the cancer cell and have less side effects, right? So I think that's also very exciting. So I think what I would like to see is us move away from chemotherapy as much as possible, because it really is a very crude treatment that I think we could just do better.
Sort of along the same lines, regarding postmenopausal cancers, it seems that tamoxifen generally had much fewer side effects. If prognosis is relatively good, wouldn't that be the preferred therapy over other AIs?
Yeah, so the basis of using the AIs is on a series of trials that all showed a benefit for the aromatase inhibitor over tamoxifen, but it was pretty modest. And in one of the larger trials that compared anastrozole or Arimidex with tamoxifen, that showed that less patients had a recurrence with Arimidex, but there was no improvement in survival. So, so the benefit is very modest. I think the reason that we tend to use them is because there's less serious side effects with aromatase inhibitors. And what I mean by that is that when in postmenopausal women, tamoxifen is associated with an increased risk of uterine cancer. Now, it's a very modest increased risk. So the risk in anybody, any postmenopausal woman is about 1 per 1,000. The risk of endometrial cancer, it goes up to 4 per 1,000 with tamoxifen. So it's a 0.4% increase. But also things like clots in the lung or the leg are more common in postmenopausal patients. And there's also, especially in older women, a higher risk of strokes as well. So I think that's the reason that we lean towards aromatase inhibitors. So it's more the less serious side effects. It's more that they have less serious side effects. I think they have more, personally, I think they have more side effects if overall, but I think they have less serious side effects rather than the difference in efficacy.
Okay. I really think that most of the questions have been covered, like in one way or another. There were just so many questions, and I feel like your presentation did such a great job of answering them. So I just want to thank you, Dr. Ruth O'Regan, for being a part of this seminar tonight. I want to encourage all the folks, as you're wrapping up tonight and click out of the webinar, to please answer the questions that pop up on your screen. We'll share that feedback among our program staff as well as with Dr. O'Regan. And I just thank you all for being a part of it. Thank you, Dr. Ruth O'Regan, for being here tonight.
Thank you for having me.
Absolutely. Thank you. Good night, everyone.